There was an interesting study, Dr. Hachinski, from North Carolina, which looked at, do we really need to do CT scans after we give tPA to patients? Or is it an unnecessary thing? Does it change the way you behave? Can you describe that, what was going on in that study?
Well, what they did is they performed CT scans after the given tPA. And then they made some decision based on whether the fact there was hemorrhagic transformation or not. But I think a crucial question is, what type of ischemic stroke was it? If it was atrial fibrillation, for example, the recurrence rate is highest in the first 48 hours, and clearly there you would take a chance and certainly anticoagulate. Even, it's a balancing act, it's not an absolute, but clearly you would try to balance the likelihood of recurrence versus making the hemorrhage transformation worse. On the other extreme, if it was a lacunar infarct, then you wouldn't need such a rush, you may wait a few days. And if it's a large vessel disease, depends what else is involved, and so you make a judgment on that. As to the question whether it's worth doing, well, in their experience, it wasn't worth doing, but on the other hand, it is a single center, and we don't know the details about what were the cases. And they themselves call for further research as a question worth addressing.
Well, you know, everybody today is so cost conscious. I recognize that they want to avoid radiation, but I think the real reason they're talking about doing things like this is, are we wasting money doing a CT scan? So if you're managing a patient and they're not fibrillating, you know they're not fibrillating, will you make a decision of whether to put them on an antiplatelet agent regardless of what you find on the scan?
No, I think that's part of the decision making. And I would have said that whatever a CT scan costs, it's really small compared to salvaging some brain or hurting someone's brain. So I think the equation has to be much more complex than simply doing it or not doing it. And I would encourage them to, first of all, identify what type of patients they have, where exactly was the transformation, what was the etiology, and encourage others to actually take a look as well, because the practice elsewhere may be different.
But I also think it comes to a broader issue too, just not cost. It's this whole idea of we're not very good at stopping things in neurology. You know, we're good at starting. Innovation is wonderful. It's exciting. We love doing it. But the flip side of that, kind of in stopping some things, or if we don't need to do it, how do we kind of de-innovate in a way that is practical? And you know, we get MRIs in everyone now.
Right.
So are there instances where we may not, in tPA, able to just maybe just get the MRI scan, because it may give you some more information, and you know, there are subsets of patients that we may not have to do the guideline routine of getting a CT scan, and maybe rethink that.
Well, I totally agree we should be looking at whatever we do, because after all, when tPA was first given, I don't think that post-tPA CT scans were routine. And yet the outcomes of many of the centers were similar. And in fact, there's a major registry called the SITS registry, SITS. And this is established by the European community to make sure that the tPA was safe in the hands of the practitioners. And of course it showed that it was. And many of those centers did not have those post-CT scans. So it's a question worth asking. And as a matter of fact, there may already be evidence from that very large registry, which is now international. It used to be European, but now they have Asia, Latin America, etc. So some of the answers may lie in those studies. The question hasn't been asked. And yes, I agree with you that there's only thing that's more difficult to get something started, and that's stopping it.
So let me ask you something. Our listeners are interested in a seasoned stroke doctor like yourself. A patient comes in, they have an ischemic stroke, and they're fibrillating.
Right.
And after you give them the tPA, they haven't changed. Or maybe they've even improved. Do you care if there's blood in there or not? Are you going, since you said in 48 hours they could throw one, are you going
well, they can, yeah. I'm very much afraid of atrial fibrillation. It's really quite deadly. In other words, the damage that it causes typically is larger than some of the other ischemic strokes. So again, I think it'd be difficult to prescribe because you have to individualize the age of the patient, what are the comorbidities. But yes, I would have thought that atrial fibrillation is the one that you really need a lot of decision making. And for those cases, you may well want to have a CAT scan.
And if you did find blood or hemorrhage, just again getting your opinion as a seasoned stroke specialist, if you did find hemorrhage in the post-scan, would you delay aspirin if it's a non-fibrillating
Oh, aspirin.
stroke?
Well, aspirin is not very good at preventing atrial fibrillation.
But if it was a non-fibrillating, it was a
The non-fibrillating. I think he'll be, on balance, I'd be inclined to intervening, to put him on the antiplatelet agents, because I think we get afraid of some blood in the brain. Now, to be fair, the fact that they're symptomatic is a very crude assessment, because that damage is likely to be subtle, and we don't test acute stroke patients for the cognition, for example, which would be a much more sensitive index. So the fact that they were asymptomatic doesn't really mean that they were asymptomatic. It means they did not have the sort of symptom we pick up, say, with the stroke scales, and that's very gross.
And will we ever be able to get it down to a formula, or is it basically still going to require judgment of the clinician?
Thank God it'll always require judgment, because things keep changing. They keep changing. The age of the patient, the type of the patient, what we can look at, what treatments we have. So I see it's an unending quest. I mean, there always will be, that's one thing that I think humans are particularly good at. They can balance things. You cannot program a human to the extent of a computer, because if it could be programmed, we'll have the computer programs do the decision making. And then there's the human element, because we always sort of think, well, this is the best medically. But let's say you have a 93-year-old. Well, I'll give you a specific example. We had a 103-year-old lady admitted to emergency, and she came with a major stroke. She couldn't talk. She was paralyzed on the right side. And so we had to make a decision, do we treat her or not? So she couldn't give her consent. So we got her son, who seemed more frail than she. The story was that she had been living, she was way out early in her life, and she only had vision in one half of one eye. But she'd been coping in her own department. She was totally self-sufficient. And so we asked the son, and she said, well, doctor, we told her, we don't know, and nobody's ever given a tPA at someone at this age. And I said, we may harm her. And he said, doctor, she'd rather die than live as a cripple, she said. So we went ahead. She fully recovered, 103. But the interesting thing is, she never made it back to the apartment, because she was assessed by the social services, and they decided that she didn't have enough vision to be living on her own.
Which probably was true before
I know that. I mean, it's well-intentioned, but I mean, it couldn't. Well, in fact, we have published that article in Neurology, and that case rather, and it may be a world record. It's a way of saying that making the point that there'll always be judgment. So maybe people live to be 110, so they give it to 110. I don't believe in ageism. In other words, every person is entitled to being judged on their own merits, and also patient preference. That's the major one. We think what's best, and maybe scientifically the best, but a person may choose something different, and we should respect that. That's the last step. What are the patient's values? What are the preferences? And there again, you get into humanity, which is so diverse that we'll always have a job.
Thank you.